Let's begin with our today's lecture, which is Anaphylaxis Management. First thing which we will discuss is what anaphylaxis is. Anaphylaxis is the allergic reaction that occurs as a result of antigen that enters the body, and that antigen initiates the production of antibodies, and those IgE antibodies, they act on the cells like basophils and mast cells, and those basophils and mast cells as a result produce the chemicals like histamine, prostaglandins. Different chemicals are produced that cause different reactions like increased permeability and increased capillary dilatation or distension, that are responsible for all the changes that occur as a result of anaphylaxis or allergic reaction. Here, if we see in this diagram, this is the entrance of antigen in the body, and these different people are allergic to different substances sometimes, or they are allergic to drugs like penicillin, Septron, and then we have allergies to different foods. Some people are allergic to peanuts. Allergy is very common. Fish allergy is very common. In the same, some people are allergic to beef products. So all those allergies, as a result of those allergies, antigens enter the body, and those antigens initiate the production of antibodies in the body, and subsequent exposure to the same allergen or antigen cause the anaphylaxis or allergic reaction. So first, in anaphylactic reaction, the first exposure is important, so patient needs to be sensitized to those allergens or antigen. Here you see the picture showing the hives or urticaria as a result of the anaphylactic reaction or allergic reaction, and this anaphylactic reaction is these hives and urticaria are very pruritic, very itchy, and they are very disturbing. You can see the redness of the eyes. There is swelling around the eyes also. So all these are the very characteristic feature of the anaphylaxis or anaphylactic reaction. And in this diagram you can see the antigens. They are attacking the cells and initiating the production of antibodies which attach to the surface, and subsequent reaction or exposure to the same antigens initiate the anaphylactic reaction. What anaphylactic reaction is, as I mentioned, the antigen are also known as allergen. The antigen or allergen, they enter the body. A lot of patients who have seasonal allergies, they are allergic to the pollens produced during the spring. So those are also allergens or antigens. So antigen or allergen, they enter and they act on the B cells. And then IgE antibodies are produced. These are IgE, immunoglobulin E antibodies. These are produced in response to the entrance of allergen or antigens into the body, which bind to the B cell, and this cause production of IgE or antibody E. This then attached to the surface of basophils or the mast cell. These are the basophil or mast cells, and the antibodies, you can see they are attaching to the surface of the mast cell or basophils. Next, again, now first there is exposure to the antigen, and as a result of that exposure, antibodies are produced, IgE antibody. Now the person has IgE antibody present in the system. Against that antigen, the person is allergic to. So now the exposure to the same antigen, subsequent exposure to the same antigen now will initiate the antigen antibody reaction, and then it cause, here you can see, subsequent exposure to same antigen. Now there are antibodies present on the surface of the basophil or mast cell, and you see subsequent exposure, these antigens, they are attached to the antibodies, and this initiate the reaction. Antigen bridges gap between two antibody molecules, release of histamine and other mediators. So here you see these antigens, they bridge the gap between two antibodies. Here one antibody, another antibody. Here this is bridging the gap between two antibodies all over, and they are attached on the surface. And this causes initiation of release of chemicals like histamine and some other chemical mediators also. And as a result of this antigen antibody binding, combining, release of histamine, other chemical mediators occur, and the different changes can occur as a result of that, including the increased permeability and capillary distension. So there is increased permeability, increased leakage, and also there is distension of the capillaries, which are the smallest blood vessel. And these are the changes that occur as a result of histamine and other chemical mediators. And all these other further changes are because of this increased permeability and dilatation. Some people, as a result of allergic reaction, seasonal allergies, they have all that runny nose and running watery eyes. Because of this dilatation and increased permeability, all these different changes occur. So if we summarize, the anaphylaxis is allergic reaction, which can be severe allergic reaction and can be fatal and cause death. It might be mild allergic reaction or seasonal allergies to different pollens present in the environment. It can be as a result of drug, insect bite, and different foods also cause allergic reaction. And first there is exposure to allergen or antigen. Those react on the B cells, leads to the formation of antibodies, IgE antibodies, which attach to the surface of the mast cell and basophils. Now subsequent exposure to the same antigen, the antigen attached to they break the gap between antibodies which are present on the surface of the basophils, cause increased permeability and capillary distension. Next, what is anaphylactoid reaction? Anaphylactic reaction is a little different than anaphylactoid reaction. In this anaphylactoid reaction, we don't need any prior sensitization. As we mentioned in the previous slide, that we need the exposure to the antigen, which leads to the formation of IgE antibodies. In this case, anaphylactoid reaction, no prior sensitization is required. Mast cells again, or basophils, the same cells, cause release of histamine, prostaglandins, leukotrienes, proteases, and we have proteoglycans. So the main difference between, remember, anaphylactic reaction and anaphylactoid reaction. In anaphylactoid reaction, we do not require prior sensitization to the antigen, and again the mast cells and the basophils, they release different chemicals. Important, histamine is very important, proteases, proteoglycans, leukotrienes, and prostaglandins. So that's the major difference between anaphylactic reaction and anaphylactoid reaction. Now next we will go over some causes of anaphylaxis. The insect bite and stings is very common cause of anaphylaxis. So insect bites and stings, sometimes even the individual doesn't know what happens, and the bite of the insect or sting, they cause anaphylaxis, and they have hives like we saw in our first diagram. So the hives and urticaria, which is very itchy and it's pruritic, so that occurs as a result of insect bite, or it may be very serious, like causing shortness of breath, wheezing, swelling. So depending on the how bad is the anaphylactic reaction, the symptoms depend on that. So insect bite and stings is one very common cause. Next, food exposures. Different foods can also initiate the anaphylactic reaction. Medications and latex exposure. Some people are allergic to the latex and they cannot put on the latex gloves also. So they have an alternative available in the form of non-latex gloves. And when they wear the latex glove, they have itching on the hands and they have rash. That tells them that they are allergic to latex. So there are different medications also that different people are allergic to. Penicillin was one very common drug causing anaphylactic reaction. So test dose of penicillin is usually given before initiating the treatment. So if person is allergic to penicillin, they can have that reaction. Then we have idiopathic factors. Sometimes we don't know what is the causative agent that is causing the anaphylaxis, and there are a lot of idiopathic factors which we don't know what the person is allergic to, but they have anaphylactic reaction. Then exercise. Exercise initiate the anaphylaxis also. So all these are very common causes of anaphylaxis or anaphylactic reaction. Next, we will talk about some red flags. Red flags are what are the warning signs, we can say, that if the patient have in the history any red flags, any warning signs which we should pay attention to prevent the anaphylaxis, what are those? Previous emergency airway intervention, very important. If the patient tells, I had a previous emergency airway intervention, suddenly have problem in the breathing, there is wheezing, stridor, shortness of breath, it's a very, very important red flag or the warning sign. So previous emergency airway intervention. Next is progressive course GI symptoms. Different allergies to food also can cause GI symptoms like nausea, vomiting, pains. All these progressive course GI symptoms is also included in the red flags. Epinephrine requirement, if there is a history of the patient that they required or they used epinephrine, epinephrine is effective against anaphylactic reaction. So if there is a history, previous history, that's also the red flag. Airway compromise and anaphylactic shock. So all these red flags may be due to airway compromise, or it may be due to anaphylactic reaction, or it can cause anaphylactic shock. Next, syncope, orthostatic symptom. Usually they are indicative of anaphylactic shock. Recent contrast during the imaging, against lot of people have anaphylactic reaction as a result of different contrast medium used for the imaging technique, and if there is a history of recent use of contrast during the imaging, that is also which cause anaphylactic syndrome from contrast allergy. Then if there is chest pain and shortness of breath, that is also due to cardiac ischemia and dysrhythmia. Abdominal pain in pregnant women, miscarriage by anaphylactic syndrome. So all these can occur as a result of anaphylactic syndrome or anaphylactic reaction. There may be syncope, orthostatic symptoms, which is the change in the blood pressure when changing the position. If there is a history of recent use of contrast medium during imaging, if there is chest pain and shortness of breath, cardiac ischemia and dysrhythmias, and we have during pregnancy there is pain, it might be miscarriage as a result of anaphylactic syndrome. Difficulty speaking and dysphonia. So difficulty speaking and dysphonia also a red flag because of the swelling in the throat and in the mouth. Usually there is vocal cords are affected and there is dysphonia and difficulty in speaking. Dysphagia and tightness of the throat, difficulty. Dysphagia is difficulty in swallowing, and if there is tightening of the throat. Shortness of air or shortness of breath if there is cough. And there is also oropharyngeal or facial swelling. So there is swelling on the face, around the eyes, cheeks, they are all swollen. And there is also oropharyngeal swelling. Next, there may be anxiety or confusion also as a result of anaphylaxis. And all these different changes, they are suggestive of either angioedema, in which there is swelling on the face. You can see there is swelling of the lips, around the mouth, periorbital region. So it might be due to angioedema or airway compromise. Airway compromise itself can cause changes like shortness of breath and dyspnea, or it can be as a result of anaphylaxis. Then we have respiratory failure also. So all these are the red flags in the history of the patient with anaphylaxis. Some other red flags, carcinoid syndrome. Carcinoid syndrome also is sometimes have symptoms which are very closely resembles the anaphylactic symptoms. So, and the hereditary angioedema. You can see there is swelling of the hand in the hereditary angioedema. The family history of similar symptoms or history of similar episodes with no antigen. So both of them, there is no antigen exposure, no antibody, but the symptoms associated with these conditions, you will have a family history with these, and they closely resemble the anaphylaxis. Now, what are some examination findings? We can say that these are the red flag findings of anaphylaxis. We have the irregular pulse. There is dysrhythmia from hypoxia, stress, or epinephrine. So findings, irregular pulse, it may be dysrhythmia. The rhythm of the heart is not normal, which can be from hypoxia, decreased supply of oxygen, stress, or epinephrine. Mucous membrane involvement. What will happen on the mucous membrane? There is angioedema or Stevens-Johnson syndrome. Wheezing, cyanosis, and hypoxia, respiratory failure. So on examination, we can see angioedema, wheezing, cyanosis, hypoxia, all these as a result of respiratory compromise, respiratory failure. These features are present. Irregular pulse due to dysrhythmia. Then hoarseness and stridor is present. Hoarseness of the voice, we already mentioned that there is dysphonia, difficulty in speaking because of the swelling in the throat, involvement of the oropharyngeal region. There is swelling of the vocal cords, inability of the or restricted movement of the cords, and there is stridor and hoarseness of the voice. Tachypnea and air hunger is also present. So we have tachypnea, fast breathing, and air hunger because of all those changes, respiratory compromise because of the oropharyngeal swelling. There is difficulty in breathing, and to overcome that, we have tachypnea, fast, rapid breathing, and there is air hunger. Oropharyngeal and facial swelling. Then we have hypoxia, which is the late sign as a result of all these changes. swelling, poor breathing, respiratory compromise. There is hypoxia, decreased supply of oxygen to different parts of the body, and different organs also slowly they will start showing the signs associated with the hypoxia. So hypoxia, late sign, then need the oxygen for the to recover this hypoxia. Airway involvement again, and there might be angioedema which cause oropharyngeal or facial swelling. You can see very bad angioedema, swelling of the eyelids, excuse me, and there is swelling around the lips also, and the facial swelling, very, very characteristic appearance of angioedema. Next, we will go over what are some important questions we need to ask the patient with anaphylaxis. The first very important question is, when did the symptoms start? So what were the circumstances in which the symptoms start? Whether the the person is exercising when it starts, or if they are working in the bushes, trees, something might bitten the person. That's very important to ask. If they were eating something, if they took some medicine or took some drug. So all these are very important questions we should ask. When did the symptoms start and what were the circumstances? Next, any known allergies, any new exposures? Again, very important question. If patient know they are allergic to some drugs, if they are allergic to some food and they accidentally used it, or if there are some new exposures. Suppose if the allergy, or if there are hives and urticaria on the hand and they use the gloves, latex gloves, which can cause the reaction, it's important that it may be something new exposure or something new caused the problem. Next, nearby events when symptom arose. Again, that's an important question. Any trouble breathing or talking. If they have any problem in the breathing or talking, we already went over all those red flags which are important because of the conditions like swelling, oropharyngeal swelling, and respiratory compromise and respiratory failure. We should ask if there is any problem in the breathing or talking. Anyone in family had symptoms like this? So again, some allergies might be seasonal allergies, pollen allergies, some drug, food allergies. So ask if these some allergies are present in the family also, or if they have somebody in the family who have the same symptoms. Next, associated symptoms. Associated symptoms are important, and the first associated symptom which we will discuss is the airway edema. Edema is the swelling or fluid in the airway, and what are the features associated with this? So airway edema. Throat tightness. When there is edema or swelling, there is tightening of the throat and there is dysphagia. And if we already talked that the same symptoms also occur in the anaphylaxis also. So some associated symptoms in conditions like airway edema, there is throat tightness and dysphagia. Also, airway edema or fluid in the airway as a result of allergic reaction or anaphylaxis also cause dysphonia and stridor. So all these features we already talked in the red flags, and then now they are what are the conditions that cause these symptoms is the airway edema or presence of fluid in the airway as a result of anaphylaxis cause dysphonia, stridor, tightness in the throat, and dysphagia. Also, it causes coughing and sneezing and respiratory distress because of edema of the airway. So if you see, this is dysphonia and stridor causing the involvement of vocal cords, tightness in the throat, cough and sneezing, and there is also respiratory distress. All these are because of the edema present in the airways. And then we have nasal congestion. Nasal congestion, cough, sneezing, very, very common in anaphylaxis. One of the basic symptoms of anaphylaxis or any allergic reaction is runny nose, congestion, cough. All these are very common. Next, another associated symptoms and what are the symptoms associated with that is angioedema. Angio is the term used for the blood vessels. Angio are blood vessels. So angioedema. There is edema of the face and eyelids. So edema of face and eyelids as a result of angioedema. You can see very, very clear picture. Edema of the face and eyelids. Then we have edema of the lips and tongue here. Again, very characteristic of angioedema. Edema of the uvula. Uvula is this hanging structure, and there is also edema of the uvula. Edema of the hands and feet. So all these are the characteristic features of angioedema, and angioedema causes swelling of the face, lips, and uvula, and also swelling of the hands. And we already discussed that angioedema can occur as a result of anaphylaxis, and it can cause all these different changes. Next condition which we will talk is the bronchospasm. Bronchospasm is also very common associated symptom of anaphylaxis. And what happens in bronchospasm, there is a narrowing and spasm of the bronchioles, which are the branches, the trachea, which is the windpipe, divides into right and left bronchi, and these right and left bronchi gives further branches known as the bronchioles, and these bronchioles have again tertiary bronchioles also, where we have alveoli and where exchange of gases takes place. So if there is spasm or narrowing of these bronchioles, then there is shortness of breath, dyspnea, wheezing. All these features can occur, and this is very characteristic of condition known as asthma, which itself usually occur as a result of allergic reaction. So bronchospasm, what it causes dyspnea and chest tightness, tightening of the chest. Then we have wheezing and coughing. There is also tachypnea and retraction. fast breathing to overcome that air hunger. The breathing is increased, there is fast breathing, and there is a retraction. Intercostal muscles are retracted because of those that forceful breathing. They try to overcome that breathing deficiency. So that's very to overcome the air hunger, to get enough oxygen. There is also retraction. So the very, very characteristic features of bronchospasm. We have wheezing, tightness of the chest, shortness of breath, there is coughing and tachypnea and retractions. Next, there is another condition known as distributive shock. Distributive shock is shock itself. What is shock? Shock is low blood pressure, decrease in the blood pressure, there is hypotension, and patient might lose consciousness, there is loss of consciousness, and patient is not alert. So there is dizziness and syncope, weakness, anxiety and confusion, hypotension, tachycardia, fast heart rate. So all these are features associated with distributive shock. There is dizziness, syncope, weakness, anxiety, confusion, low blood pressure, and tachycardia. Gastroenteritis, again, it's an important associated symptom of anaphylaxis. And what happens in gastroenteritis? Abdominal cramps and pain, especially if there is anaphylactic reaction as a result of some food allergies and any ingestion of food that the patient might be allergic to. It causes abdominal pain, cramps, and discomfort. Then there is nausea, vomiting, and diarrhea and bloating. So all these are the features of gastroenteritis. Some other associated symptoms, urticaria. Urticaria is pruritus, rash, and flushing. So in urticaria, there is pruritus, itching, very bad itchy urticaria. There is rash and flushing, redness. Raised erythematous well. So there are raised red lesions or rash. As a result of increased secretions, we mentioned that the release of histamine and other chemical mediators as a result of allergic response, as a result of anaphylaxis, cause increased permeability, and increased permeability and dilatation cause increased secretion, and these increased secretions can cause rhinorrhea, runny nose, bronchoria, and there is lacrimation, watery eyes, and nasal congestion. Very, very important common features of anaphylaxis or allergic reaction. And there is also bronchial secretions and drooling from the mouth. Next, physical examination of the patient. We have vital signs. What are the changes in the vital signs? And vital signs include TPR, which is temperature, pulse, respiration, and blood pressure. There is hypotension, decreased blood pressure. The pulse is fast, rapid, tachycardia, and the temperature is normal. So anaphylaxis is not associated with high temperature or fever, but there is low blood pressure because it can cause syncope or shock, or there is also fast pulse, or there is fast heart rate. Next, what are the changes in the lungs, pulmonary changes? There is wheezing, and this wheezing indicates that there is bronchospasm. In the extremities, what are the findings? There is cyanosis, bluish discoloration of the nail beds, and that is because of respiratory compromise, hypoxia. Hypoxia is the leads to cyanosis. Cyanosis is bluish discoloration of the skin, and it's very common in the extremities first, so the nail beds are commonly affected. What are the changes in the nervous system? Neurologic, there is agitation, unconsciousness, or there might be seizures. So all these are the findings on the physical examination. There is hypotension, tachycardia, normal temperature. There is wheezing indicative of bronchospasm, cyanosis, and there is agitation and unconsciousness. Next, what are some physical findings in the integument or the skin? We have urticaria. That's the urticaria, very characteristic of anaphylaxis. This type of rash, that's the urticaria. You can see it's less pigmented or less red in the center and dark on the side, and this urticaria is characteristic of the allergy. Angioedema. We already talked about angioedema. There is swelling of the face, lips, tongue, and this is the angioedema. There is erythema and pruritus. This is the erythema and pruritus. Cyanosis and diaphoresis. Cyanosis, bluish discoloration, and diaphoresis. All these are the integumentary findings. Findings in the head and neck, we have hoarseness and stridor, swelling of the eyelids and lips, rhinorrhea and nasal congestion, and drooling and lip or facial cyanosis. So these are all the findings in the head and neck. Cardiac and abdominal findings. In the heart, there is tachycardia, fast heartbeat, crampy abdominal pain, and there is tenesmus. Next, what are some conditions which needs to be differentiated from anaphylactic reaction or allergic reaction? The first differential diagnosis is hereditary angioedema. One, we talked about angioedema as a result of anaphylaxis. This is hereditary angioedema, and there is no involvement of anaphylaxis in hereditary angioedema. There is decreased C1 esterase inhibitor levels, decreased serum C4 level, and there is on fiber optic laryngoscopy there is edema of the upper airway. So there is decrease in C1 esterase and decreased serum C4. So all this leads to hereditary angioedema. Next differential diagnosis, we already mentioned about this carcinoid syndrome. There is increased serum and urine level of 5-hydroxy 5-HIA. So this is 5-hydroxyindole acetic acid. So this is their increased level of 5-HIAA. It's the carcinoid syndrome, another differential diagnosis. Factitious anaphylaxis, Munchausen's anaphylaxis, that's another differential diagnosis. Vasovagal reaction, monitoring and emergency department observation. So all these are differential diagnoses. We have hereditary angioedema, carcinoid syndrome, vasovagal reaction, in which we need to monitor the patient in emergency department, and then we have factitious anaphylaxis. Next, Chinese restaurant syndrome. Chinese restaurant syndrome, usually what the patient just gives the history that they were eating in Chinese restaurant and they have this reaction or this problem. So that's the history and no definitive test for Chinese restaurant syndrome. Systemic mastocytosis, no available test to differentiate from anaphylaxis, this condition also. MCSLC is again whatever is the specific disorder that leads to the condition. And then scombroid poisoning, again elevated level of urine histamine is present, and FDA analysis. So all these are the differential diagnosis or different conditions that needs to be differentiated from anaphylaxis. Next differential diagnosis is pheochromocytoma and serum sickness. In pheochromocytoma, there is elevated level of urine catecholamines. So pheochromocytoma, again, patient is anxious, confused. They have elevated level of catecholamines. That's the differentiating feature. And there is also hyperglycemia, hypercalcemia, and erythrocytosis. Increased glucose, increased calcium, and an increase in the red blood cells. Serum sickness is there is elevated sedimentation rate and creatinine level. So again, pheochromocytoma and serum sickness needs to be differentiated also. CBC with eosinophilia, depressed complement levels. Now the diagnostic testing. We have the lab studies. What needs to be performed is serum histamine, tyramine, MC tryptase, and IgE levels. Very important, all these tests needs to be done. Electrocardiogram is another diagnostic testing showing some dysrhythmias, non-specific ECG changes in acute cardiac condition. Radiologic studies is again generally non-specific. What are some general treatment principles of patient with anaphylaxis? Antigen removal. Exposure to antigen should be avoided as much as possible. If we exposure to pollens is initiating the reaction, we should go outside less, and then we should put the mask on the face. If we know that we are allergic to some food, that food should be avoided. Any medicine we are allergic, patient is allergic to, that needs to be avoided. So the very important is prevention, and that is antigen removal, and exposure to antigen should be minimal. Next, we have airway control. If there is compromise, ventilatory support, that's very important. Circulatory support, epinephrine administration, secondary medications in which antihistamines are very, very commonly used. Next, epinephrine. What's the drug we use for anaphylaxis, and what's the dose of that drug in adults and in the children? So epinephrine is the drug. The adult dose is 0.3 to 0.5 milligram in 1:1000 solution intramuscularly every 15 minutes. And then 0.1 milligram, 1:10,000 solution, slow IV push. That's immediate treatment, should be given immediately. And then in children, 0.01 milligram per kilogram in children, it's according to weight, 1:1000 solution every 15 minutes. Next, again, epinephrine IV infusion, 1 to 10 microgram per minute, titrate to effect, and 0.1 to 1 microgram per kilogram per minute in children. Then diphenhydramine, 25 to 50 milligram intravenously or intramuscularly every 4 to 6 hours, and 50 milligram orally every 4 to 6 hours. In children, 1 to 2 milligram per kilogram intravenously, intramuscularly every 4 to 6 hours, and 2 milligram per kilogram orally 4 to 6 hours. Another important, cimetidine is important for any gastric complications, gastroenteritis. So cimetidine, 300 milligram orally or intravenously, intramuscularly every 6 hours, not recommended for children. Prednisone, steroid. Prednisone is 20 to 60 milligram per oral every day. And then we have 1 milligram per kilogram oral per day. Anaphylactic syndrome drug dosages. What are some drugs that are used for anaphylactic syndrome? Albuterol when there is bronchospasm, wheezing, and there is shortness of breath, albuterol. Adult dose is 0.5 ml, 0.5% solution in 2.5 ml via nebulizer every 15 minutes. In the pediatric, 0.03 to 0.05 milliliter per kilogram, 0.5% solution in 2.5 ml nebulizer every 15 minutes. Other drugs for anaphylactic syndrome, we have glucagon, 1 milligram intravenously every 6 minutes till hypotension resolves. Dosing not definitively established in children. Methylprednisolone, again 40 to 250 milligram intravenously or intramuscularly every 6 hours, that's adult dose, and then 1 to 2 milligram per kilogram IV intramuscularly every 6 hours is the pediatric dosage. H2 receptor antagonist drugs, adult dose 50 milligram intravenously over 5 minutes, 150 milligram orally 2 times a day, and the pediatric dose is zero point 0.5 milligram per kilogram IV over 5 minutes. Pediatric dosages, as you saw, is given per kg, so it's according to the weight. And then 0.25 to 2 milligram per kilogram per oral every 12 hours. Some special patients, first we will talk about some potential drug interactions. Beta blockers are pro-allergenic and drug interaction can occur. So beta blockers are pro-allergenic. Antidysrhythmic agents are another drugs which cause interaction, and then epinephrine therapy. Glucagon infusion may be useful. Resistant bronchospasm. If patient has resistant bronchospasm and if it's not getting better, we need bronchodilators and epinephrine. IV magnesium, vitamin C, naloxone, and glucagon. Now, what's the disposition of the patient with anaphylaxis? How we should position them? First, it's based on clinical experience. A lot of physicians, when they work in the clinics, in the hospital for such a long time, usually they know how they need to disposition that patient and how that patient should be managed. So it's based on the clinical experience. Asymptomatic or aggressive treatment. Histamine receptor antagonist, desensitization therapy, and antigen removal. Pearls, pitfalls, and myths. Pitfalls, we have a failure to administer epinephrine early, failure to recognize contraindications, failure to admit high-risk patient, failure to prescribe a corticosteroid, and failure to observe the patient. All these are pitfalls. Failure to administer epinephrine, admit high-risk patient, corticosteroids, all these are very important. Next, some myths. We have patients with anaphylaxis always look sick. That's one myth. Epinephrine and antihistamines. Airway compromise always follow time course. And then no relapse after patient gets better. So all these are myths, beliefs, and they are important. So that was all about the lecture, which is Anaphylaxis Management. Thanks for watching sqadia.com.